Good evening, everyone. Welcome to Cornerstones Best of DDW in IBD 2023 for New Zealand webinar. I'm happy to introduce tonight Professor Richard Gearry, who'll be bringing you our Best of DDW program. Lastly, I'd like to thank our supporter for this activity. Cornerstones receive a generous, unrestricted educational grant from Janssen to support this program and truly appreciate their contribution. I will now hand over to Richard Gearry, who will begin the webinar. Thank you.
So thanks very much, Jo, and welcome everyone tonight along to the Best of DDW and IBD for 2023. So it's my pleasure to present this to you tonight. As mentioned, support for this activity is made possible through an educational grant from Janssen. I'm very grateful for them for continuing to support this year on year. And also the opinions that are expressed tonight represent the faculty, myself and others, not necessarily Cornerstones or Janssen. So for those of you who don't know about Cornerstones, essentially the process is that prior to Cornerstones, a number of us get together from around the world and look at all of the abstracts that have been submitted to DDW and awarded posters or oral presentations. We go through those and then identify posters and oral presentations that we think may be of interest, and then attend those and select in groups those presentations that we think are the most clinically relevant. So even though there might be some great science presented, if it's not clinically relevant, it doesn't make the cut for Cornerstones. We then present all of these abstracts in a final meeting at DDW to the group where the selections are made for the final slide set. Now, the final slide set is about 90-something slides, and I've decided to be kind to you, and we've gone through and reduced that down to about 40. So there are additional slides that I won't present tonight, but the whole slide set will be can be downloaded from the chat box as mentioned before. And during tonight, even though we're not in the same room, obviously, if you have questions, please put them in the question box, and at the end of each section, I'll stop and go through those and discuss those as we go. So we'll get underway now. The faculty are familiar people from other years that you probably recognise. The fellows are here. This is Akhilesh's third year as a fellow. The first time he went in person though, which was a great opportunity. There is Akhilesh on the right, third in, along with other fellows from parts of the world in Chicago. So the 7 areas that we go through tonight are listed here. I won't read them all out, but we'll flick through these one by one. And just before I go through the talks, the top 3 take-home messages that Miles Sparrow, Susie and I thought from the point of view of Australasia were, firstly, the new data on upadacitinib, which is a Janus kinase inhibitor, including achieving hard endpoints of induction and maintenance of endoscopic response and remission, and data on fistula healing. Some of the surgical strategies in Crohn's disease were very interesting this year, which I'll present to you, including early surgery for isolated Crohn's disease, postoperative recurrence with specific types of anastomoses, and also some information on vedolizumab in the postoperative setting. And finally, the VIEW study, which is looking at withdrawal versus continuation of thiopurines in ulcerative colitis patients in deep remission on combination, which is also interesting and we'll come to soon. So starting with epidemiology, natural history and prevention of IBD, this is one of the smaller sections, so I'll just go through this quickly. So many of you will know of the GEM project. The GEM project stands for Genetics, Environmental and Microbial Determinants of Crohn's Disease. This is a large international study of over 5,000 healthy first-degree relatives of people with Crohn's disease, and it was initiated in 2008 and includes over 50 first-degree relatives of people with Crohn's disease from here in New Zealand. There's now 15 years of follow-up, and obviously this group of people are at increased risk of getting Crohn's disease, but because they were recruited before they developed Crohn's, it provides a unique insight into the potential causes or things that may be going in a preclinical state. So the 4 studies that I'm going to highlight from the GEM study are here. The first of them, number 1, suggested that exposure to parental Crohn's disease in the perinatal period was associated with an increased risk of Crohn's disease. So in the study, they compared patients, first-degree relatives, of people with Crohn's disease who went on to develop Crohn's disease and those who didn't, with and looked specifically at those who had a parent with Crohn's disease in their house during that perinatal period to determine whether that window of risk at that point in time may be associated with an increased risk. And although the confidence intervals are relatively wide, certainly it was shown that offspring exposed to a parent diagnosed with Crohn's disease during that period had an increased future risk of getting Crohn's disease, suggesting that not just the family history was important, but maybe the timing of that risk could potentially be important as well. The second study, number 2 there, showed that an increased risk of alcohol, there's an increased intake of alcohol, aspartame, and docosahexaenoic acid was associated with Crohn's disease associated metabolites. So what they found was that those people who've been on to get Crohn's disease, if you look in serum, you can identify metabolites that were increased in those people, and there were some dietary constituents, namely those mentioned there, that were increased in those people, suggesting that there may be an association between those and the metabolites, but it's an association only. The third study at the bottom left showed that being in a multiplex family with more than one affected first-degree relative with Crohn's disease significantly increased your risk of getting Crohn's disease, as opposed to if you just had one first-degree relative, as you can see on the Kaplan-Meier curves there. So again, this has been shown in other studies, but shows that the GEM study is consistent with those as well. And finally, number 4 study there showed that there were alterations in serum metabolites in the pre-diagnostic period. It means that these metabolites related to gut barrier function and inflammation predicted Crohn's disease developing subsequently. And again, the question here is, if you have these markers and they are highly predictive, and these ones aren't that highly predictive, but if they were highly predictive, could you potentially do low risk interventions in this group to reduce the risk of getting Crohn's disease subsequently? It's too early to go there yet, but I think that's where we may be heading potentially, if we can get more accurate prognostic markers. So this study here actually has data from the GEM study, but also a number of other important studies. So this is looking at anti-integrin alpha V beta 6 autoantibodies and showing that these predate ulcerative colitis diagnosis and also are associated with worse outcomes. So there were 4 studies, 2 preclinical studies, the PREDICT study, which came from the US military, where people have blood tests done at intervals, and then some of them end up getting inflammatory bowel disease further down the track, and you can look back at their blood samples to see whether these or other markers were being expressed. And what you can see on the top graph on the right is that those people with ulcerative colitis at periods before developing ulcerative colitis had higher titers of the antibody, or significantly higher titers of the antibody than healthy controls. And the bottom two figures show that if you had these antibodies, that you are much more likely to have adverse outcomes with regards to your ulcerative colitis. So these were not only predictive of subsequent diagnosis, but also predictive of a worse outcome. Again, not yet ready for prime time, but I think interesting to show these pre-diagnostic markers. There are many studies looking at diet and IBD, and these are 2 studies that are looking at dietary factors and the subsequent risk of having a flare of inflammatory bowel disease. So the study on the left is looking at self-identified Hispanic population with confirmed IBD that was either mildly inflamed or in remission. The primary outcome was a composite outcome of a flare defined using steroid use, hospitalization, etc. And they looked at a population-specific, culturally relevant diet questionnaire, and then used machine learning to cluster the different types of diet into different groups. And what they found was that cluster 4, which you can see on the graph on the left, which is the purple cluster, was associated with a significant reduction in IBD flares compared to people who were consuming other clusters of food. And the cluster 4 was a starchy vegetable, a culturally a diet that's consistent with Hispanic culture, as opposed to a more westernized diet, if you like, suggesting that there was an association between these starchy vegetables and tropical fruit with a lower clinical activity and fecal calprotectin in Hispanics with IBD. So suggesting that diet could potentially play a role in increasing or decreasing the risk of a flare. The study on the right is the PREDICT study from the UK. So this is patients with IBD who were prospectively recruited from about 50 sites around the UK. They were in clinical remission, and their habitual diet over the prior 2 to 3 months was assessed using a food frequency questionnaire. And the primary outcome was time to first flare, and they looked for a range of potential associations. And when they compared the meat intake on the lowest quartile to the highest quartile, they found that those in the highest quartile had a higher risk of flares compared to those in the lowest quartile. Again, there are issues with the study. It's an association study. There are a lot of potential confounders that may not have been adjusted for. But I suppose it's now showing that there are some signals that need further investigation with regards to types of food that people may want to consume. I don't think, again, at this point, I would recommend that people have no meat or anything like that. It's more just identifying that these associations have been made, and we need to do more work to clarify what's going on. Okay, so that first section is very quick, and that's the end of that section. I'm just going to flick back to the question box to see if anyone's typed any questions in. Everyone's a bit shy this early in the evening. That's okay. I'm sure people will have a bit more to say, so please feel free to type your questions into the question area, and I'll keep on chatting away into the next section, and we can stop and go through those questions when we get to them. So the next section is current and emerging therapies, non-biologics, including small molecules. A lot of the presentations in this part of the Cornerstones presentation are about drugs that we don't have, but I think hopefully give us an idea about what might be on the horizon. So when we look at the treatment options for IBD at the moment, we used to draw the line below methotrexate and not have much else, and then subsequently we've had access to vedolizumab as an anti-integrin, anti-P40s in the form of ustekinumab, and the anti-TNF alpha drugs as well. But of course, there are a number of other drugs in development, such as anti-P19 drugs that are more specific for IL-23, and also the Janus kinase inhibitors, tofacitinib and upadacitinib, and S1P receptor modulators, ozanimod and etrasimod. So we'll go through some of the data around a range of these agents tonight. So the first data I'm going to present is from upadacitinib for induction and maintenance of inflammatory bowel disease. Here we can see patients who were randomized to either upadacitinib or placebo and induction for the first 12 weeks, and then subsequently the responders who were randomized went on and had either upadacitinib 30 milligrams, 15 milligrams, or placebo. So quite good numbers out to 52 weeks, as you can see here. So the first thing that they showed, looking at the top slide, is that the UXL and UXC data out to 12 weeks showed benefit in active drug versus placebo. It was more useful in those patients who had not received a biologic in the past. You can see that the delta is different there, but also achieved endoscopic remission, although slightly less so in those who had had prior biologic failure. With regards to the maintenance data for endoscopic response and remission, again, reasonable data out to 52 weeks for both doses of drug, 30 and 15 milligrams daily, compared to placebo. So reasonable data there. Now, the other thing they found is that usually you would give induction for 12 weeks, but if people didn't respond after 12 weeks and had induction at 45 milligrams daily out to 24 weeks, you still got a bit of an additional benefit in that. So a prolonged induction with the small molecule can still be beneficial as well, as you can see here with ongoing clinical response and with extended induction on those bottom graphs there. What about fistulizing Crohn's disease? Well, they've drilled down into the UXL and UXC and UENDURE data and identified those people with fistulizing disease. So 126 had perianal, 19 had intracutaneous disease. And the induction outcomes here, looking at fistular activity, external closure of the openings, complete resolution of draining, and greater than 50% complete resolution of draining does show activity, with about 50% of people getting one or either of those outcomes for induction. For fissures, again, D and E below that also look good. The maintenance outcomes not quite so good overall. Certainly, there's some benefit for external closure, but it didn't last probably quite as long for those looking at resolution of drainage, etc. But again, some of the data for endoscopic remission and response that you can see there was good. So to me, I think there is some benefit for induction. For maintenance, perhaps not quite as good as we would like, but some activity there either way. So the other question is, well, is this drug safe? As we mentioned, this is a Janus kinase inhibitor, selective inhibitor, and the safety data that's being seen from these studies out now to almost 300 weeks in the long-term extension studies didn't show any new signals. So the things that they were particularly interested in was around venous thromboembolism, around malignancy, around major cardiovascular events. And again, there were no new signals or worrying signals that came out of this in the longer term data that were presented. One of the other questions is that if you try upadacitinib, can you try that in patients who have already had a different Janus kinase inhibitor in the form of tofacitinib? So two studies here, they're both small, suggested that in a small proportion of patients they can get benefit even if they didn't respond to tofacitinib. So it's a bit like switching, I suppose, between classes in an anti-TNF drug. It appears that you can switch between classes, drugs within this class as well, and you still get some benefit in that regard. One of the big questions that's coming out now is for the JAK inhibitors, can you use these in a similar way to how you might use steroids? So these drugs work quickly, they're an oral therapy. So in this study, which was a single center study looking at patients failing IV corticosteroids with ulcerative colitis, with acute severe ulcerative colitis, they were treated with upadacitinib 30 milligrams BD from when that was started to the end of their admission until CRP normalized. Now, if you look at this group, they were a sick group of people, so most of them had prior advanced therapy, presumably with anti-TNF or other drugs. Two had prior TOFA. They were followed up for quite a short period, but a significant proportion of this tough group achieved steroid-free remission. And while there were some significant side effects, overall, this for a sick group showed some very good short-term outcome data. So there are some more formal prospective studies going on for this class of drugs in this group of people, and that will give us better answers. But I suppose it is giving us a different view on how we could treat acute severe ulcerative colitis potentially. All right, so one of the other questions overseas is which drug should you use if someone is failing anti-TNF alpha drugs? So we're very lucky in New Zealand that Pharmac made that decision for us. So thank you, Pharmac. So we don't have tofacitinib, but we do have ustekinumab. But it's reassuring in this multi-center retrospective study of adult patients with UC who had failed an anti-TNF, who have started on either tofa or ustekinumab, that really there was no difference between those two drugs with regards to the rates of people who entered corticosteroid-free clinical remission. The difference, though, is that of course these are retrospective data, so there may have been specific reasons why the doctors chose one of these drugs over another that aren't captured in the study. And there were some predictors of ustekinumab failure, including if you'd failed a biologic before or a number of biologics before. Given that ustekinumab is a biologic, you're more likely to fail this biologic as well. But overall, no difference between ustekinumab and tofacitinib in anti-TNF failure patients with ulcerative colitis. And we'll talk a bit more about this group a little bit later as well. So just a slide on etrasimod. So etrasimod's a S1P modulator. Essentially what this class of drugs does is it traps lymphocytes in lymph nodes, which means they can't traffic out to areas of inflammation to continue to drive that inflammation. So it's stopping migration to the area of tissue. So this is a phase 3 study. So this is a registration study looking at etrasimod. It's an oral drug. And what it showed was effective. It was effective for steroid-free clinical remission, endoscopic improvement, and histological remission at week 52. So significant effects here you can see on the bottom left with regards to those three outcomes. And on the right there, you can see those who had maintained week 12 induction efficacy continued out to week 52, and about 66 to 70% of the, or 80% of those people achieved those outcomes. So certainly evidence of efficacy. We don't have this drug or ozanimod in New Zealand. Talking to people overseas, they tend to use it for the more sort of moderate UC rather than the severe UC patients. But as I say, we don't have that option here at the moment anyway. And just quickly, with regard to safety of this agent, it appears relatively safe. There were concerns with this drug, this class of drugs, that it may cause some issues with regards to ophthalmic eye complications and also arrhythmias, but that hasn't been borne out in some of the studies. But nonetheless, it's something to be aware of. So that's the end of that section. I was going to see if anyone's got any questions yet, or let me just open up the question. So Dave, okay, so Dave Rowbottom, thanks Rich. Any data on the length of stay in oral UPA in those acute severe colitis patients? So it wasn't presented, David, at the meeting. The abstract will come with what's there, but I don't recall that. I think that I mean, a lot of these patients wouldn't normally get out of hospital. The way I would see it, they'd already failed an advanced therapy. They're on IV steroids and failing those. So I think this was a super sick group. So Charlotte, does it look like we'll get upadacitinib? Well, the good thing about the drug, I suppose, is that it is currently available in New Zealand as a third-line agent for rheumatoid arthritis. So the fact that it's in the country is a huge step forward compared to other drugs that aren't in the country. The issue will be obviously the cost and also how well we can convince Pharmac. So I think as another class of drug goes, this class of drug will be great for us to be able to access. It's an oral drug, works in a different way. It's a small molecule. So I think that's what we're always after, is different mechanisms of action. I think we don't want more of the same, but I'm not sure at the moment, but certainly there's a big push, there's a big push as a community, I think, for us to have new drugs, and this will be the class of drug that we would probably be after, accepting that there are a whole lot of other drugs that we'll talk about tonight just coming up. All right, so I'll push on with the next section. So as you know, overseas and in New Zealand as well, there are biosimilars, which are drugs that are like a generic drug, I suppose, for an originator, but are slightly different in that the molecule will never be exactly the same. And that's raised concerns about whether switching from an originator to a biosimilar may be associated with a loss of efficacy or an increase in immunogenicity, or both of those things. So these are data from almost 300 patients from Edinburgh who had not just one switch, but sometimes 3 switches over time to 2 different biosimilars, or else 3 biosimilars. So there's certainly a lot of different changes going on. And essentially, across this large population, they didn't see any significant change in efficacy with regards to partial Mayo score or Harvey-Bradshaw index. No significant changes with CRP or fecal calprotectin. No changes with immunogenicity, and overall persistence that was not significantly different between these. So they concluded that these multiple successive switches from infliximab originator biosimilars were effective and safe, irrespective of the number of switches, based on the data that they have there. Now, again, Pharmac made that decision for us, so we don't have to worry. But in other hospitals around the world, the contracts may change year by year for the suppliers of these drugs, so these data are quite important. All right, so last year I spoke about the Strident study. This was a study from Australia, which looked at patients with Crohn's disease who had symptomatic strictures with associated inflammation biochemically, and they were also assessed using a novel score called the obstructive symptoms score, which were symptoms that were associated with their stricture. It was an unvalidated score, which was a bit of an issue. And these people were randomized to either 2-to-1 to either high dose adalimumab with then combination therapy with a thiopurine, or standard adalimumab with ability to increase the dose. And when we say high dose adalimumab, this was 160 milligrams weekly for 4 weeks, so very high dose induction followed by standard therapy versus standard induction therapy. And the primary endpoint was an improved obstructive symptom score at 12 months. Now, the obstructive symptom score endpoint wasn't met, so the study wasn't a positive study. But what they've done is they've gone back and looked at those people who responded at 12 months to the drugs, regardless of which arm they were in, and then worked out, well, were these people likely to avoid surgery? So if you get a clinical response, are you likely to avoid surgery? And the answer was yes, you are. So the likelihood of surgery was 9% in those people who responded to biologic therapy, compared to 42% of people who didn't. It's slightly self-fulfilling, I suppose. If you have ongoing symptoms and you've been on lots of therapy, you may give up and go for surgery, but still I think it is useful to add that 12-month mark to determine whether people will progress or not to require surgery. All right, so this is a really unusual study. I saw Andrew Day on the call. He may have some comments on this one. I think it goes against a lot of what we believe in the adult world. So I'll just take you through it. So it's a high quality study. It's a randomized double-blind placebo-controlled multi-center study. So 35 sites, mostly in North America, I believe. And the question was to try and work out whether methotrexate co-prescription in patients with IBD who are children receiving anti-TNF was effective or not. So the primary outcome was treatment failure. The anti-TNF was managed at the discretion of the clinician, and then there are a number of secondary outcomes. So over in the States, obviously you're not an adult till you're over 21, diagnosed with Crohn's disease, starting on anti-TNF biologic and no contraindication. The patients are randomized to either low-dose methotrexate, so combination to try and reduce immunogenicity, versus placebo, and then the primary endpoint was over a 1 to 3 year follow-up period. So again, good numbers of patients, about half and half in each group. And what they found was that if you had combination therapy overall, your treatment failure rate was less than if you had monotherapy. But interestingly, there was a difference between the two anti-TNF alpha drugs. In the infliximab group, there was no difference between treatment failure if you had combination therapy or monotherapy. So that's not what we would expect in general with combination therapy compared to monotherapy with infliximab. However, for adalimumab, there was a significant difference whereby monotherapy was associated with a significantly greater risk of loss of response compared to combination therapy. So on the basis of this study, the conclusion is that compared to adalimumab monotherapy, adalimumab and methotrexate experience a reduction in risk of treatment failure. There's no differences in infliximab, and the only real difference between the groups that we could elicit was that the infliximab levels are monitored more closely than the adalimumab levels, so it's possible that there could have been much more dose adjustment in the infliximab group. But again, I'm not sure that I'd be saying that this is something that we should necessarily take on. But again, I might be interested in Andrew's perspectives as whether things are different in children to adults potentially. All right, so we're going to talk a little bit about IL-23 drugs now. So many of you will hopefully be aware of and may have started prescribing ustekinumab. So ustekinumab is an anti-P40. You see that the P40 subunit is shared between both IL-12 and IL-23. So when you use this drug, you block both of those pathways. On the other hand, the P19 drugs, of which there are 4 listed here, risankizumab, mirikizumab, guselkumab, and brazikumab, only target the P19 subunit, which is only found on IL-23, so it's much more specific blockade. So ustekinumab has been available in the rest of the world for quite some time, in New Zealand for about 5 months now. And some of these other agents have been available in New Zealand, and some of you may have been involved in the risankizumab studies that were done in New Zealand, and also currently and recently the guselkumab studies, which have been done in New Zealand as well. So that's the sort of landscape, if you like, of IL-12, IL-23 drugs. So looking at some of these drugs in a bit more detail, I think these next 2 slides are really important and useful studies with regards to how we practice in New Zealand. So this is a phase 3B randomized double-blind multi-center study, so a prospective study, high quality, of patients who are receiving ustekinumab and flare. So these are people who are failing standard dose ustekinumab. So they all had they're all on subcutaneous 8-weekly ustekinumab, and they were randomized after having secondary loss of response to either a single IV dose of ustekinumab and a subcut placebo, or an IV placebo and subcut ustekinumab, and then continued on 8-weekly ustekinumab subcut after that. So it was really just to decide, would a single reinduction dose of IV be effective compared to continuing with the same therapy. So what you can see here is the clinical response rates and between the groups at week 8 and week 16, which is the primary endpoint, were not significantly different between the two. Clinical remission, also not different between the two. There was a difference with regards to endoscopic remission but no change with the endoscopic response. So based on CDAI primary endpoint at week 16, it wasn't met. There was some benefit with regards to biomarkers and endoscopic outcomes, but overall a negative study with regards to the primary outcome. And I suppose the question would be, in New Zealand, if you had failure of therapy, would a single IV dose be useful? it would appear from this study that that probably wouldn't be the case. Now, usually when I'm doing this live, people go, but what about if you go to 4-weekly subcut? Here are two studies that address this, which is why I think these two slides are so important for local practice. So the first study is a multi-center observational retrospective study. So immediately it's retrospective. So the way that people got into each of the groups I'm going to describe in a minute won't be random. It'll be biased, and we need to understand that when we're considering the results. So there are two groups. There's the must group, which there were 59. Those people got standard IV induction, and then right from the get-go, they were on 4-weekly subcut drug, as opposed to the standard group who had IV ustekinumab followed by 90 milligrams 8-weekly, as we would use in New Zealand, and then they could later have a dose intensification if they needed to. And the primary endpoint was patient-reported outcome, clinical remission, and a biochemical change. And what they showed in this retrospective study, which will be biased, was that there was a significant difference between those people having success from 4-weekly ustekinumab subcut compared to those having standard dosing. So it didn't work for everyone, but certainly there was a benefit and a significant difference between the two groups. So the next study is a retrospective study as well, and this is probably slightly more typical to what we'd see in New Zealand. So here are 350 patients who were treated with ustekinumab. Of those patients, 239 had an inadequate response between 6 and 12 months. And of those people, 123 were escalated to 4-weekly and 116 continued at 8-weekly dosing. And what they found was that if you shorten the interval from 8 weeks to 4 weeks, there was a significant improvement in clinical outcomes, particularly with regards to endoscopic remission, steroid-free clinical and endoscopic remission, mucosal improvement, and so on and so forth. So again, this is probably similar to what we would see in New Zealand with regards to how we might be able to dose escalate if you're able to get compassionate supply through Janssen, and we can discuss that in the question time. So I think these two slides, this one here, looking at IV reinduction and dose escalation, are important. I would say with this slide, though, it's only retrospective data, but nonetheless, it is real-world data, which we have to acknowledge. All right, so moving on now to chronic antibiotic refractory pouchitis. So this is a small group of patients, but a group of patients who have a lot of morbidity. It says here, as we know, about up to 10% of patients with ulcerative colitis may get chronic antibiotic refractory pouchitis after proctoclectomy. So this is a very small group, just 22 patients, but a prospective multi-center open-label study of people receiving IV induction with ustekinumab, then 8-weekly drug out to a year. The primary output was steroid-free remission, or is determined by a modified pouchitis disease activity index at week 16. And what they found was that there was a significant reduction in the total clinical subscores, endoscopic subscores in 14 of the 22 people, but similar with similar changes, non-significant reductions in CRP and calprotectin, as you can see on the right. So for me, this suggests that this is a drug worth trying in this group of patients. There's also data from the EARNEST study that we presented in Cornerstones last year that's been published in the New England Journal recently as well, which is probably a slightly more robust study using vedolizumab for the same group of people. So again, more options for this difficult group of patients, and that's certainly beneficial, I think, overall. All right, so these are data from Australia and from Rupert Leung's group. And what they're doing is they're looking at patients with luminal Crohn's disease, and they're using PBS data, so data from the Pharmaceutical Benefit Scheme in Australia, just looking at drug persistence. Now, staying on a drug is usually a function of whether the drug is working or not, or whether it's effective, and also whether it's toxic or whether there have been significant side effects. So it's a combination of those two things. So what they did is they looked at this data. They propensity score matched the patients, looking for persistence, looking at age, immunomodulator use, and line of therapy. So there were a lot of people involved in the study. There was 1,446 patients, lots of different treatments across different drugs that were used. And if you were having a drug for the first time, so you were bio-naive and you were randomized to infliximab, vedolizumab, well, not randomized, if you're given infliximab, vedolizumab, or ustekinumab, there's no difference in treatment persistence at all as a first-line agent. However, if these drugs were given as a second-line agent, you'll see on the Kaplan-Meier curve on the right here that ustekinumab had the best persistence over the anti-TNF alpha drugs and over vedolizumab, suggesting that ustekinumab was associated with ongoing efficacy and lack of toxicity in patients who are bio-exposed with Crohn's disease. So I think this is helpful with regards to the New Zealand situation, in that we do have a choice of all three of these agents second line, and we can see here that in luminal Crohn's disease there appears to be a benefit of ustekinumab over the other two. First line, of course, we don't have access to ustekinumab, so either of those other two mechanisms of action would make sense. All right, so this is the VIEWS study, which again I think is an interesting study, and one that we should just spend a little bit of time discussing. Again, a study of Rupert's from Sydney, looking at ulcerative colitis patients and whether you should continue a thiopurine in combination therapy with vedolizumab or not. So it was a prospective multi-center single-blind RCT, ulcerative colitis patients on vedolizumab, standard IV therapy, and thiopurine. They've been on that for more than 6 months, and they're all in steroid-free clinical remission, and they were randomized 2-to-1 to withdraw or continue the thiopurine. The primary outcome was the week 48 drug level. So did the vedolizumab concentration in the blood, was it different between the two groups if you continued or stopped a thiopurine, with a number of secondary outcomes there as well. So the results, there were 62 patients in the study. It was appropriately powered. 42 withdrew the thiopurine, 20 continued. The multivariate analysis showed that histological activity at baseline predicted disease relapse. That's not new, but reminds us that if you are going to stop a drug, restaging someone can be quite helpful to predict how things might go. And there's no significant difference in adverse events between the groups. But although it didn't affect the trough level, in the subgroup of patients who previously failed anti-TNF, those people who stopped thiopurine had significant increased risk of getting a raised calprotectin, a raised CRP, of having worse inflammation endoscopically, of having worse histological changes, and a combination of those. So, and again, in this group of patients who those who failed anti-TNF, it would appear that the benefit of thiopurine co-prescription with vedolizumab is significant compared to stopping thiopurines in this group of patients. So it wasn't the primary outcome of the study. For that, it was negative, but these patients who'd failed anti-TNF did not do well as well if they stopped the thiopurine as combination therapy. That's probably slightly counterintuitive to what we've been doing up until now, but certainly something that we may want to discuss in a minute. All right, so this is the Reprevio study. So this is a multi-center randomized controlled study comparing vedolizumab postoperatively after ileocecal resection to placebo. So patients were randomized 1-to-1, and after 26 weeks of randomization, they underwent an ileocolonoscopy, and the primary endpoint was endoscopic recurrence of Crohn's disease with a number of secondary endpoints. And the bottom line was that these patients in the red who received vedolizumab had a significantly lower Rutgett score than those who received placebo, suggesting that their disease was downstaged by having maintenance vedolizumab. Now, a number of these patients did have had previous anti-TNF, about 50% in each group. I don't have the data for whether the drug was effective in those patients or not, but overall, certainly there was a benefit of vedolizumab in the postoperative setting. All right, so guzulcamab is one of the P19 drugs that I mentioned earlier, and it's effective in moderate to severe ulcerative colitis. These are the data from the phase 3 study, and showed that essentially in patients with moderate to severe disease, that the benefit of guzulcamab intravenously was significantly greater than placebo, suggesting it's a safe and effective treatment for moderate to severe ulcerative colitis. So overall, again, good data coming out about these P19 drugs as well. All right, just going to speak a little bit about this study. We wouldn't normally talk about phase 2 studies, but this is really interesting because this drug was developed by a company called Prometheus, which has got a lot of the gastroenterologists from Cedars-Sinai were involved in this. And the drug just sold we think for 8 or 10 billion to Merck. So interesting, and also, and that's a new mechanism of action, and also has an interesting companion diagnostic test that goes with it. So these are induction data. It's an intravenous drug that goes for TNF ligand 1A. So these were moderate to severely active patients with ulcerative colitis, and they were randomized 1-to-1 with to this agent or placebo, and the primary endpoint was clinical remission at week 12. And essentially, they met their outcome, as you can see here, with regards to increased clinical remission, but also increased endoscopic improvement and clinical response. Mucosal healing did very well. But interestingly, the one on the far right, you can see here the DX plus or minus. This refers to a genetic based diagnostic test, which they haven't named. But if you have this gene, then you are significantly more likely to respond to the drug than if you don't have this gene. And again, this is coming back to the personalized medicine now with regards to your risk of benefit and potentially identifying those people who are at increased chance of doing well on the drug and identifying those for prescription. So again, interesting with regards to how that works together. Unfortunately, it was only about a quarter of the patients who had that polymorphism. All right, so there was a lot in that section. I'll jump back to the questions. So Charlotte, do we have data about adalimumab biosimilars? And I'm guessing that's with regards to switching between those. So most of the data that's published on the biosimilars doesn't appear to show a significant difference between originator and other. Nor switch, there were some suggestions, but nothing major. I think we've all had examples of patients who haven't done as well on biosimilar adalimumab compared to originator, and I've got probably 3 or 4 who have gone back onto originator and swear they're better. But I think they're anecdotes rather than regular things. So Andrew, interesting data. Not sure why methotrexate might have different effects to adalimumab than infliximab. Part of the rationale will reflect the North American concerns hesitation about thiopurines. Have a number of patients on methotrexate but haven't selected using according to biologic type. So I think that's right, Andrew. I mean, there's a big push against thiopurines in North America, and certainly methotrexate's their co-prescription drug of choice. But again, the data are interesting. David Rowbottom, does the drug level equate to clinical response? I'm not sure which one that relates to, whether it's the VIEW study, potentially. That was what they did the primary outcome based on, because they wanted to power it for that, and they didn't think they'd be able to power for a clinical outcome. I think they were surprised that some of their secondary outcomes showed a benefit in the VIEW study, unless it was a different study that you're talking about. And Charlotte, how does the vedolizumab for 24 weeks compare to metronidazole data? So I think that the patients did receive metronidazole in that study as well, but I don't know that specific question would have been answered, metronidazole versus vedo out to 24 weeks. I suppose to me what it says is that it just provides us with different options that we have now in this post-operative setting. This time when patients have basically what should be a normal intestine, and we can then prescribe these drugs in this way. And David's clarified it's for vedo. Yeah, so I agree, David, that it doesn't equate to clinical response. The reason they powered it on that was that they had some preliminary data that showed that they expected to see a difference in vedolizumab concentration between combination therapy and not. So the question was really a pharmacokinetic question. That's why the study is really interesting, because it didn't show that, but it did show loss of or changes in efficacy as seen endoscopically and with biomarkers as well. Cool. All right, we'll kick on. So we're up to disease activity monitoring and therapeutic drug monitoring. One of my favourite slides is coming up. Not quite yet. So this study looks at acute severe ulcerative colitis and the use of ultrasound scan to detect those. So in this study, it was a multi-centre prospective study of patients with acute severe ulcerative colitis, 32 of those, half of whom responded, half of whom required rescue therapy. And they found that bowel wall thickness from day 0 to 3 predicted steroid non-response very early. So they're suggesting here that assessing the bowel in other ways, not just endoscopically, can provide some prognostic information in that regard. The numbers are very small though, And I always think that in ulcerative colitis, it's so easy to look with a scope that it's probably what we do unless you had ready access and expertise with ultrasound. All right, this is Akalesh's study, which made Cornerstones this year. So this is looking at the disease severity index. So the disease severity index was developed about 5 or 6 years ago as a way to try and work out when someone says, how bad is your IBD? This is a way of trying to say, well, it's this severe or not very severe at all, if you like. So there was a complicated conjoint analysis that went on by experts to try and identify which factors were most important. And you can see on the slide on the right, the different variables that go into the score and how they're weighted. So we've got this prospective cohort in Christchurch, the NIDA cohort, which all had scopes at the start, and then we followed these people prospectively. But then in addition to that, we combined our data with data from a number of other centres in France, the US, and Australia. And what we were able to do was to show that if you hit a disease severity index of greater than 23, you're significantly more likely to end up having a complicated disease outcome, which was classified as basically use of steroids, admission to hospital, surgery, etc. So what this is, it's another prognostic marker, and most of the things that you can measure there are quite easily measured. Akalesh, because he gets bored quickly, is also replacing now in the disease scores mucosal lesions with calprotectin or myeloperoxidase. It shows that it's just as predictive doing that. So we think this is a way of potentially identifying patients who've got a high risk of progression and maybe would be ones who you might look to treat more aggressively. I mean, that risk of progressing is odds ratio of almost 10, even though the confidence intervals are wide. An overall probability of a complicated course over 2 years of 50% compared to 10% is quite a significant difference. So we think this is quite interesting, and certainly might be looking to use this more readily. And using CC Care, how we're managing our patients at the moment, we can measure this sort of data quite easily. All right, so many of us will use biomarkers such as fecal calprotectin, but one of the questions that remains is, can you use calprotectin easily in patients who have an ileostomy? We know that generally for colonic disease in patients, the calprotectin can be very useful. For ileal disease, if you've still got your colon there, it may be not quite so useful, but there's less data from patients with an ileostomy. So this was a retrospective cross-sectional study, which will have issues around it again because it's retrospective, and I think could have brought in a number of biases here, but over 100 patients just. And what they found was that if you had a calprotectin of greater than 59, you're more likely to have significant bowel inflammation than if you had one less than that, in which case you're much more likely to have no inflammation at all. So they think that calprotectin is a useful biomarker. I think it's probably a useful rule-out test if your calprotectin is less than 50, as you would with maybe patients who don't have inflammatory bowel disease. It can be helpful. But I'm not sure 59 is the magic number exactly for me. I think I'd just use a standard 50, probably be fine. All right, so this is my favorite slide. So this is looking at artificial intelligence and how we might be able to use that for IBD care. So I know how much we love it when our patients bring in a photo of their poop to show us exactly how things are. So instead of them bringing it in, they should send it to the AI machine, because if you do that, the AI machine looking at pictures of feces in the toilet bowl has got a similar accuracy to fecal calprotectin in predicting endoscopically active disease in patients with ulcerative colitis. And there's the pictures that correlate with the endoscopic findings that you can see there on the left. So I think that's a pretty fantastic study, but I'm not quite sure what to make of it. The next study is almost equally as fantastic. So if you're interested, you can buy one of these things called an emerald machine, which the maroon arrow is pointing at, and it goes on the wall in your room, and it passively picks up data on sleep, breathing, gait, other things like that. And again, it can predict a flare and remission with the accuracy that approaches fecal calprotectin. So if you don't want to send a photo of your poop, you can buy an emerald box and put it on the wall, and it will passively collect all this information for you. So there you go. The two studies on the right are looking at computer vision quantification of gut inflammation. So typically we measure an SES-CD in patients with Crohn's disease, or a Mayo score for patients with ulcerative colitis. And that requires scoring to be done by humans. So why get a human to do it when a computer can do it differently? So rather than using those scores, they basically just looked at the bowel and looked at the amount of ulceration and worked out the computer worked out itself the severity of inflammation that was present. And when they did that, it correlated much more closely with steroid-free and non-steroid-free clinical remission for Crohn's disease, and also much more closely for steroid-free remission for ulcerative colitis. And last year, there were data suggesting as well that if you use this instead of an endoscopic score, you probably need significantly less patients in clinical trials just because they're so much more accurate. So this stuff's all coming, and we've already got AI on our endoscopy, obviously, but this will be coming more and more into our practice, and this is just some of the AI stuff that was presented. All right, so that was a pretty quick session as well. No questions there. I thought I'd definitely have a question on the photos because I thought they were just fantastic. So please don't send your photos to me, just send them to the AI machine. Okay, so looking at treatment-related adverse events, safety, and vaccines now. So this is a meta-analysis looking at exclusive enteral nutrition before intestinal Crohn's disease surgery. So looked at a number of studies done over time and combine those together. Most of them weren't randomized studies, but nonetheless real-world experience, if you like. And what they showed was that there was a significant reduction in skin and wound infections and intra-abdominal sepsis in those people who had pre-operative exclusive enteral nutrition. Now, one of the issues is how long you need to give this for. Most of these studies will have given a reasonably long course. We think that that might be problematic. Patients struggle to stay on the treatment, and maybe a short course may be useful, which is something we're going to be looking at locally in Christchurch, not just for IBD, but also not just for Crohn's disease, but also for cancer surgery, whether a short course might be helpful. But it would appear here that certainly there is a benefit and a reduction in septic complications and skin and wound infections. So these are data from Denmark, and we all know in Denmark and Scandinavia you can't do anything without someone writing it down somewhere. So they've got fantastic administrative databases. So what they did here is that we know that standard opioids or traditional opioids are associated with very poor outcomes in patients with inflammatory bowel disease. So they wanted to know whether tramadol may be associated with the same IBD-related complications. So they used nationwide cohort of adults with Denmark. They looked at initial users of tramadol and persistent users of tramadol and compared their outcomes with patients who were getting traditional opioids over that period. And the outcomes of interest were infection, bowel obstruction, surgery, and mortality. And certainly it appeared that with regards to infection, IBD-related surgery, and mortality for initial users and mortality, infection and bowel obstruction, there was a reduction in that risk in those taking tramadol in particular. So there's a signal here. Again, this will be highly biased in that it's not a randomized study looking at these, and there'll be factors that determine why people received either of those pain relief medications. But again, just reminding us of the importance of getting people off opioids if we can. All right, so this is another interesting study, and this one came from Cedars-Sinai in Los Angeles. So they went back over all of their patients who'd received thiopurines over a 17-year period. So there were 2,500 of those, and they were all genotyped for TPMT, NUDT15, and one of the HLA haplotypes as well. And what they found was that, as we know, that NUDT15 was associated with an increased risk of leukopenia. But in addition to that, it was associated with an increased risk of pancreatitis, increased risk of flu-like symptoms, and any adverse event at all. Whereas almost a third of patients who had a NUDT15 mutation ended up with a significant side effect. Now, if you look across the different ancestries, we can see that it's not seen in Africans. Only 2.5% of Europeans carry the variant. But we look at East Asians, that's up to almost a third. And also South Asians, about 1 in 7 having these mutations as well. And in Latin populations, a significant proportion too. So the question is, where does this fit in? Does it really matter? Well, we can measure NUDT15 in Christchurch. So if you're measuring TPMT, you may choose to do that. Looking at these data, I think it would be clear that it's the East Asian and South Asian and potentially Latino groups, although we may not have many of those people in our population, but they're the groups that we may be more likely to want to request NUDT15, and then certainly it may swing you as to whether you would use these drugs or these thiopurine drugs with caution in those groups if they have a mutation, or just elect to go to a different agent altogether. So I think this is helpful, and to me it just backs up the importance of looking for these probably in these two groups here rather than in all groups. All right, so we'll just check the question boxes again. So David, whether traditional opioids oral or could they be IMIV? These were oral opioids, so these were people who are prescribed outpatient opioids, and probably reflects the questions that have come from in the US where there's the opioid epidemic. David Robin, obviously if parental likely to be an inpatient and more aggressive disease, so were they comparing like with like? For that meta-analysis, it would have been making sausage. It would have been a whole lot of different stuff put in together, I think. I think certainly that a lot of those studies will be retrospective. A lot of them, the decision to give exclusive enteral nutrition will have been very different to anything else. So this is enteral rather than parenteral. So looking at enteral nutrition rather than parenteral, but as I said, the data will be mixed, but again, most of the signals tend to be positive. What's the turnaround for the NUDT15 assay? I'm not sure, but it will be batched because it's genotyping, so it won't be super fast. I suppose the question for me would be if you had a newly diagnosed South Asian or East Asian or Latino person with IBD, should you do it with your TPMT near diagnosis? That would probably be where I would be positioning that test myself, but happy to discuss that further. Cool. Okay, we'll push on. So disease-related outcomes, including these things here. So the first study looked at treat-to-target strategy. So many of us will be aware, and hopefully if you haven't, you should have a read of the STRIDE2 document. So these are data that, or recommendations reminding us that we need to have targets when we're treating people. And the first target we'll always have is making people feel better with symptomatic response. But then after that, it's also about normalizing CRP or calprotectin, and also then mucosal healing as targets that we want to do. And the key thing is if we don't meet those targets, we need to change our treatment, treatment in some way by optimizing or switching to another drug potentially. So given that we believe this is the right thing to do, this group did a quality improvement exercise over 38 centres over a 1-year period. And basically after each patient was seen, they were assessed with these 3 questions. So firstly, was treat to target discussed with the patient? Was there an objective assessment of inflammation performed, a CRP, a calprotectin, or an endoscopy, for example? And is there an intention to change the treatment if the target isn't reached? So very clear treat to target questions that I think are really helpful. And the intervention that was undertaken was looking at regular education sessions, reminders, etc., to see whether if you introduce that, can you improve outcome? And certainly went from a quarter to a half of the sites regularly getting a good TTT score over that period of time. Now, interestingly, when they then went back and compared the sites that did improve compared to those who didn't, there were some trends towards improved outcomes with regard to endoscopic and steroid-free clinical remission, suggesting that treat-to-target approach was effective at getting those outcomes. So I think this is useful, and I really like these 3 questions. It's sort of something you can have in the back of your mind with your IBD patients. You know, am I working in this way, and is that appropriate? And some of the targets, of course, may be very specific to the patients. They may be fatigue or something that isn't the same as what's necessarily written in the diagram. All right, so many of you will remember the LYRIC study. The LYRIC study was a randomized control study comparing a primary ileocecal resection to infliximab therapy in patients with limited ileal disease. And in that study, there was a benefit of surgery over infliximab. So this was a study called the MELODY study, and it's sort of trying to get to the same question in a slightly different way. So again, because it's Denmark, everything's written down. So they went to their registers over a 15-year period and identified those patients with ileocecal Crohn's disease who underwent a resection, and compared those who had a resection to those who had anti-TNF between 1 month and 1 year after diagnosis, so early on. And the primary outcome was a composite of one of those things there, so hospitalisation, perianal disease, steroids, or surgery. And patients were much less likely to end up on steroids or have further surgery if they had surgery at the start. And looking at that combined endpoint there, you can see that patients with ileocolic resection had a lower likelihood of that combined composite outcome overall. There are issues again with the study. It's retrospective. It's not, patients aren't randomized, so there'll be factors that may influence why patients got one or other of those therapies that may bias the results. But nonetheless, I suppose it backs up this option of a primary resection for this group of patients. All right, so the next question, if you're going to do a resection, how do you join the bowel back together? So many of you will be aware of the side-to-side and the stapled functional end-to-end anastomoses that you can see in the picture there, but there's also this other anastomosis called the Cono-S, which is a bit more complicated. So essentially for this anastomosis, they do a end-to-end anastomosis and then cut a longitudinal cut upstream and downstream, and then join that together. So you end up with a supporting column of anastomosis as well as the wider anastomosis that you can see. But in addition to that, there's a very small mesenteric resection as opposed to these other resections where you lose a lot of mesentery along the way. So in this single centre study from Naples in Italy, patients were randomised to either Cono-S or conventional side-to-side anastomosis, all done endoscopically. And a multivariate analysis, Cono-S anastomosis was the only variable associated with Crohn's disease recurrence. So looking on the right here, endoscopic recurrence at 6 months, clinical recurrence out to 4 years, and surgical recurrence out to 4 years, and clinical recurrence a suggestion there as well. So there appears to be in the single centre study some benefit of this anastomosis. It is more difficult. It takes probably another 30 to 40 minutes, they say, to do this anastomosis compared to the other ones there. And of course, it's something to discuss with our surgical colleagues. But I congratulate the surgeons on doing a randomised trial. They're not straightforward to do. It just would be good to get data from a few more centres, but certainly I think it's something to at least have a discussion. And I think the slide, I've sent it to some of my surgical colleagues just to get their opinions on it. All right, so these data are from Canada, and they're looking at population level administrative data and people with IBD and 10 age-matched controls without IBD, looking at the development of cancer over a 3 to 18-year period. And basically what they did is they age standardized it to the general population and log transformed the incidence to try and show the excess incidence, if you like, over the annual percentage change. And what they were able to show was that the rates of small bowel cancers, non-Hodgkin's lymphoma, and biliary tract cancers have all gone up in recent years compared to some of the other studies where there hasn't been such a increase with regards to outcomes like colorectal cancer, for example. So some of these, such as non-Hodgkin's lymphoma, we could argue maybe due to the increased use of immunosuppression, which may lead to less inflammation, but more immunosuppression is noted. But not all of those cancers are in this way. So I think this is interesting. I think these aren't the typical cancers that we think about, and the absolute numbers will be small, but nonetheless, it's important to consider those in our group of patients. So I'll just go back through that group to see if there's any questions here. Non-Hodgkin's lymphoma, secondary to thiopurines, we don't drill down. We haven't been able to drill down on that at the moment. I spoke to the primary author when I was in Canada recently, and they don't have those data at the moment, but certainly their thought processes are that the non-Hodgkin's lymphoma are likely thiopurine related. Yeah. All right, so getting on to near the end, I think. So perhaps 2 more sections. So patients with inflammatory bowel disease have inflammation, and if you have inflammation, you're at increased risk of cardiovascular disease. So this is shown in this enormous administrative database from the States that shows that your risk of major adverse cardiac events, your risk of heart failure, infarction, stroke, are all increased if you have IBD compared to non-IBD. So we know this, and one of the discussion points that's come up in the in-person meetings has been, whose role is it to look out for these risk factors and manage them as much as we're able to. I don't know about where you are in the country, but certainly general practice is under increasing strain, And if these patients are coming in to see us, is it okay just to say, go to your GP and get your blood pressure and these other things checked? But I think we need to be able to remind our general practice colleagues that these patients are at increased risk of these adverse cardiovascular outcomes, and someone needs to be thinking about those things, because as these patients get older, this will be one of the major reasons why they die early. And if we look at other outcomes related to this, again, in this study from Sweden, the risk of arrhythmias has increased. Highest absolute risk in the elderly onset, but the highest relative risk in young people. So again, it probably just speaks to the importance of controlling inflammation overall. And again, same cohort looking at stroke, again, increased risk of stroke. And again, it's this managing of cardiovascular risk, and certainly this thought that we need to have some maybe IBD specific guidelines for assessing and managing cardiovascular risk in this group of patients. So some of you may or may not be aware of ARFID, which is avoidant restrictive food intake disorder. This is where people restrict significant sections of their diet and end up in trouble because of that, often from a nutritional point of view. So no one's really spoken a lot about this in the past in the IBD setting, and when they've looked at it, they haven't used validated tools. So in this study, they used the well-known PARDI ARQ, which stands for PICA, ARFID, and Rumination Disorder Questionnaire, which is validated, and also a 9-item avoidant restrictive food intake disorder screen. And what they found was that approximately 20% of these patients had ARFID. Now, this group will be different to your general population. They were from a tertiary care centre, so maybe more likely to have severe disease and suffer from a range of things. And this was associated with a reduction in physical health, although not, and also with GI-specific anxiety as well. So I think, yeah, interesting data. Talking to dietitians, this is particularly difficult to manage. It requires long-term dietary intervention, psychological intervention to reverse some of what's seen here. All right, so a couple of years ago, our group looked at sexual dysfunction in IBD patients and showed something very similar to this study, which is that sexual dysfunction in IBD patients isn't really associated with disease activity, but rather is associated with anxiety and depression, which sort of makes sense. But we have to remind ourselves that anxiety and depression have many effects on patients with IBD, and we need to think widely about how we look after our patients more holistically. In this study, though, they also followed patients prospectively, and what they found was that if you treat people who do have active disease with biological therapy, their sexual dysfunction does improve. So even if patients do have active disease, if you treat those people, you will get benefits not just in their disease, but also in other aspects of their life as well, which of course is very useful. All right, so this study I don't think is super surprising, but I think it's quite got an important baseline to it, which is firstly that if you are a woman and you have IBD, you use more healthcare during pregnancy and after pregnancy compared to people who don't have IBD, and that sort of made sense to me. But one of the big outlines for this was the most common reason for hospitalization and ED visits in women was with IBD was venous thromboembolism. So just to remind ourselves of the importance of managing inflammation, reducing VTE risk as much as we're able to. All right, this may be the last slide. So these are data from Melbourne in Australia, where they've looked prospectively at a subgroup of patients from the PICCOLO study. So these are women on vedolizumab or ustekinumab who are pregnant or considering pregnancy and who are followed prospectively through their pregnancy, through the preconception pregnancy areas, and then postpartum as well, looking at drug levels from cord blood and also postpartum, and also measuring some disease activity with regards to clinically active disease and biochemically active disease. So good numbers of pregnancies, over 100, half of whom had vedolizumab, half of whom had ustekinumab, a quarter of whom overall had active disease, and there's no difference in active disease between those two groups defined by drug exposure. So throughout pregnancy, the ustekinumab concentrations remained about the same. There was a slight reduction in vedolizumab drug concentration, but there was no associated rise in calprotectin, so it was thought not to be important. When we look at the maternal drug ratio and clearance, it is higher in the infant in ustekinumab compared to vedolizumab. And in ustekinumab, the drug had completely gone from the infant by 14 weeks, whereas in vedolizumab, it was about 11 weeks, and no difference in maternal or fetal outcomes between any of those groups, the control groups or anti-TNF. So overall, their interpretation was that these were reassuring delivery and fetal outcome data for both these drugs, and we won't have much of an experience in New Zealand using these drugs in this regard. And they didn't suggest that routine monitoring and dose changes were necessary in pregnancy, and that we should just continue to manage these patients in the same way as we would otherwise.